Good afternoon all, it's Chris Schilling here. I'm a health economist with Opus and with KPMG, and it's a great pleasure to be with you this afternoon to talk a little bit about how health economics can help to inform OA policy. And I must say it's also really great to see that we as a CRE are devoting a session to health economics, and really I think that stems down to a lot of Peter's leadership. Often health economics can be kind of left to the last year, seen as a translational tool, but really what Peter and Michelle and what I'll hopefully be able to highlight today is that it is something that can be brought into all things that we do, and in fact it adds a whole lot of value when we do it that way. So what I'll be talking to you briefly about today is just what health economics can bring to policy development. I'll tell you some good news and go through some of the examples of individual research that we're already doing and have done, and how that's already informing policy. I'll then take a few minutes to talk about some of the osteoarthritis policy models that have been developed around the world, and then highlight what we as a health economics team within Opus are looking to do as well as we move forward. So without any further ado, what can health economics bring to policy development? Well, there's really two major things that I like to consider. The first one is just a real focus on cost effectiveness and value. Stephen Duckett, I'm not sure if he's listening into this one, but I've seen him present a number of times and talk about how health economists can actually keep two things in their mind at the one time, keep both outcomes but also costs. And really, that's what cost effectiveness is all about. It's that trade-off. It's understanding that yes, we can deliver great outcomes, but are we delivering those outcomes at a relatively good cost? Are we delivering value for money for our really scarce health resource spend? And so that's certainly one area that health economics can really help in terms of the policy development in osteoarthritis. The second area is really to help bring the diverse and disparate range of research that's done together into a system, into a model that allows testing and trialing of various different policy options. So what we find in the real world is that we're playing with live ammunition. So that makes things difficult to decide, well, should we go with model of care A or should we go with model of care B? And how does it all interact with all of the things that matter? How does it interact with our population socio-demographics? How does it interact with the epidemiology of osteoarthritis? And how do our treatments interact with all of that? So what health economics can do is pull all of that together into a systematic methodology, a model that can allow for what-if scenario analysis, so that we can test those things essentially in our pseudo-computer laboratory environment, and then see which ones are delivering that really strong value for money. Now, the great news is that we as an Opus team are already including health economics all the way through what we do. And when I, in preparation for today's talk, just walked through some of the publications that have been put out over the last couple of years and looked through some of the PhDs that are underway, all of those have a really strong health economics bent. When we look at Sid's work, investigating length of stay and enhanced recovery after surgery programs, all of that has really strong impacts on really the efficiency of treatment for OA and making sure that we get value for money. Jason's work has done a range of really interesting analysis on the cost effectiveness of various different options, including computer navigation. Again, a really strong health economics bent. Cade's PhD will focus on opioid use and really help to understand better patient selection into surgery. Michelle and Tim and Peter's work has obviously been really groundbreaking in creating a nomogram to again help with that patient selection to ensure that we're delivering really efficient care. Sam's work looking at trials, and making sure that we get good value for money out of our trials. Again, all of these things already have a really strong health economics bent, and that's really great to see, and something that I really urge us to continue with. I'll change direction slightly now and talk a little about two policy models that have been developed around the world to help with decisions around osteoarthritis. And the first one, and most prolific by far, is OAPOL, the osteoarthritis policy model. It's been developed and led by Elena Lucena out of the States. This model is a Markov state transition model, which means that the model has various different states of progression of the osteoarthritis, and agents, people who come into the model, people who are modelled, then transition between those states over time. And things that influence those transitions are things like a person's socio-demographics, as well as the treatment paths that they go down. One of the great things around these type of models is that they do have a health economics bent. Costs can be added to each of those states, as well as each of those transitions, so that the model can be run and used to assess different types of models of care and the cost effectiveness of those models of care. As I mentioned, it's been a really prolific model, over 100 publications since 2009, and some of the examples of research that it's assisted with include your standard cost effectiveness analysis, but also things like cost projections and surgery and prevalence projections. A second model used in osteoarthritis policy analysis is POHEM-OA. POHEM stands for Population Health Model. It was a generic model developed by Stats Canada and others that really utilised the amount of information that a statistics agency captured, and really had great insights back in the 90s, led by Michael Wolfson et al., to use all of that data to create essentially a synthetic population for Canada, using all of that information from census data, from health surveys, from all of the information from administrative use of health services. And they put all of those things together to create a really impressive microsimulation model. What Jan Kopek and his team did was extend that model and allow it to really go into detail about osteoarthritis. So it included, again, things like socio-demographics, obesity, as well as various different treatment options and quality of life under different treatment options for osteoarthritis. Now, it's a continuous time microsimulation model, which is a mouthful, but it just means that rather than having specific states that each given amount of time a person might be in, this model actually determines how long a person is in a given state. That's part of the endogenous calculations within that model. It is a much more complex model, and that's perhaps why it has been a little bit less prolific than the OAPOL model. But it does have some great examples of research that it's done, including looking at cost and quality of life projections under different types of OA policy directions. Now, you might have heard in my voice as I was talking about these two models that I really think they offer a great deal, and that I see their value. And so what the team here, the health economics team at Opus, are doing is actually working on a similar modelling capability for us here in Australia. So watch this space. What we're intending to do is to really develop a framework that can capture all of that great work that's going on around the team, and be able to incorporate it in a way that then allows for interesting policy scenario analysis to be conducted. I'll conclude quickly just by saying, well, One of the great things that's happening in Opus is that already much of what we do has a really strong health economics lens and is really policy relevant. And I encourage us all to really continue down that pathway. And then just finally to again comment that we are building a modelling platform that will really help to integrate all of the research that we're doing. And if you've got interest in that, please come and see me at some point. I'd be happy to discuss it further. Cheers. Thanks for tuning in.